to Pain in the Podcast, your place to find out everything you've ever wanted to know about pain. My name is Dr. Joseph Parsons, and I'm joined by Don Wijasoria and two very special guests today. And we're going to be talking about the relationship between patients and clinicians. Welcome in. So today, just a little brief caveat before we start the episode. In the beginning of this episode, I mentioned that Josh was in surgery. This was as a medical rotation, and he's just keen to point out that he wasn't the one doing the surgery. This was just part of his postgraduate training, just so not to mislead anyone. Either way, with that caveat in place, welcome to the episode. Hello everyone, and welcome to episode 5 of Pain in the Podcast. This week, Josh can't be with us as he is in surgery, so we're joined by two very special guests. We are joined by the founder and CEO of Pained, Charles Balcombe.
Hello!
And
oh, you are going to regret that.
And a pain specialist physiotherapist from NHS Ireland, and a great friend of mine, Becky Hunter, PhD.
Stop.
That was way better than mine.
Yeah, I think so.
Can I redo mine?
Absolutely not, no. Usually I would ask you to introduce yourselves, but you're going to get the chance now, because every week we start by telling one fact about ourselves so listeners can get to know us a little bit better. So let's start this week with a fact about you, Becky.
Okay, my fact that I am willing to share with people who are listening to this. I'm a fire starter, terrific fire starter. I am amazing at making fires. I do make me sound a bit mental, like I'm an arsonist. No, like campfires. And,
I thought just emotional ones and just like ruining relationships.
Well, that would be better. No,
but wait,
okay.
were you going for the Prodigy lyrics there?
Well, yeah.
Isn't it Twisted Firestarter?
Well,
and you've gone with Terrific.
Oh my God. From a man who doesn't sing any of the lyrics to any song correctly, are you trying to out me right now that I got this
Well, you're
lyrics
not out.
wrong?
I'm not trying to. You did get outed. So
No, I am. Oh, God's sake! I'm good at making.
we're
good at
1 minute in.
making fires.
Becky is good at making fires.
Okay.
Charles.
Good at putting out fires.
Yeah. I have somewhere between 2.25 and 2.5 nipples.
Oh my God!
Not expecting.
In a judo event when I was very young, I had an injury, and now I have 2.25 nipples.
Okay, I'm gonna need to see them now.
Is it because you had 3 and you lost 3/4 of one nipple in the judo event?
No,
Or
I
you
got
gained a quarter of a nipple?
the lapels play a big part in judo, and so I went to kind of.
Did the other person lose
They
a
didn't.
quarter
Like,
of
did
their
they rip
No,
your
yeah, and then it
nipple
grew
off?
back.
Oh
I mean,
God, damn.
kind of.
Okay, this
We're now
doesn't.
seeing it. For those of you who can't,
Right.
who are listening at home,
People
Charles is now showing us his quarter.
I got the wrong one out as well.
Oh my God!
See,
Like
you've got
2
like a double.
minutes.
Oh!
Yeah.
I kind of see that.
Yeah.
Oh, yeah.
The
2
worst
minutes.
part was I went to the wrong side of my body, and then I was like, I've just told a lie.
Oh my God!
Let's
2
see.
minutes into the podcast, and we're showing nipples already.
Exactly.
I don't know.
It's a great start.
Hey, listen. Can I clarify? Is Josh in surgery, or is he doing performing surgery? or
Josh
is
is
he having
performing
surgery?
surgery, but
Oh,
he also
okay.
broke his ankle last week, so
Oh.
he probably should be in surgery too.
Oh right. Okay.
We'll
totally.
see.
Your ankle heals well, Josh.
And yeah, that goes for all of us in the podcast. Right, Don.
That was my mum.
Okay.
Fact about you, Don.
So this is, I don't like to put this out there, but I'm on a time pressure and I can't think of anything else. But I am shit scared of birds. Mainly pigeons, but lately I've been trying to get over this.
Okay.
And so every morning I wake up and there's usually like a wood pigeon or some kind of bird outside on our fence. And I'll just like picture myself walking up to it and like touching it.
I like the imagery. I like it.
So yeah, there's progress.
Yeah.
Well, I mean, if we're bringing it back to chronic pain, there's lots to be said about graded exposure. So well done for
Thank
practicing
you.
what you
Yeah,
preach. Yeah.
Taking my own initiative.
Yeah.
Exactly. Right, and my fact about myself this week is that I am a huge basketball fan, and I own a jersey for every team in the British Basketball League, because I'm a massive nerd.
How many teams are there?
10. It's not very exciting. And then there's 2 extra teams.
Dang.
In the men's and the women's, so I own 12 in total, because there's 2 teams in the women's that aren't in the men's. Nerd! So there you go, nerd. Right, a wonderful feature that Don brought into the podcast, which is something that we have learned about ourselves.
Which I'm now
this
regretting.
week, which he regrets because he has to think of his own. So Becky, what have you learned about yourself this week?
Don, can you go first? And I'm going to have a real think, because I want it to be a doozy.
I'm feeling very nice today, so yeah, okay. So what I've learned about myself is that even after speeding and having to go on a speed awareness course, I'm still really bad at sticking to the speed limit. As Joe knows, as we were driving down to London. Yeah.
So would you say the speed awareness course did not work?
It taught me what I needed to know, because there were some things I just did not know, like when it's exactly a 30-mile-per-hour road, or when it's a 60. But now I know that, and I still just refuse to adhere to that.
Maybe Joe may have preferred if you just said that after you had dropped him back in Manchester.
Yeah, I would have liked that. I would have liked that.
He's in for the long ride now.
Yeah. But at least it'll be a quick ride.
Yeah.
Yeah.
Charles.
I learnt that my pea-sized brain is not capable of converting my 10-week-old daughter's howls into really chilled Celine Dion music. I was trying to go for, can I take this sound, convince my brain that it's Celine Dion in the next room. I learned that I can't do that. So
That's so weird. But cool, okay.
But we've all met him this weekend, and we've heard the...
She has potential.
Weird because it was Celine Dion, or weird that...
I think weird because it was Celine Dion.
Yeah.
Why Celine?
Well, because I was listening to Think Twice the other day.
Okay.
You know?
Yes, I do.
Baby, think twice.
But I'm glad you're singing just to
Yeah.
refresh me.
So I
Yeah.
get the mic. Yeah. So yeah, that was a really sad day in my life when I realised I couldn't do that.
I'm sorry.
I move on.
Sorry. Becky.
Well, I was reading a book about how intermittent fasting can help with pain. And I thought, well, I'm not going to ask my patients to do anything that I'm not willing to try myself. And I really like my food, so I was not looking forward to it. And I managed to go 46 and a half hours. I was planning for 48, and then my mum gave me a glass of wine, and I was like, yeah, no, 46 and a half is good enough. And I went, and actually it wasn't nearly as bad as I thought it was. So, which is what everybody says, but I was not convinced. And so I learned that actually I can go without food, and there might be some benefits in it. It's still got a lot to learn, whatever. But yeah, I reckon there might be something into this.
Is that intermittent fasting, or is that just general fasting?
Well, I don't know, because intermittent fasting
Suggests that you do it more than once.
It's the 18-6 thing, Becky, isn't it?
Exactly. Yeah, it's intermittent fasting when you do it once every 2 years, right? That's the one I'm going for.
Okay.
Yeah.
We actually, in the Jewish faith, we've meant to fast once a year. It's called
Yom Kippur. It's
Yom
not.
Kippur. How did you get that before me? I'm the Jew.
It's the only thing I know about Jewish culture.
I've been intermittent fasting way before it became trendy.
All right, so
It's really long intervals.
Yeah. But yeah, no, I've done that 16-8 fasting as well, and I must say I think there are huge benefits to it.
The reason I'm laughing is because I've met Charles for the first time this weekend, and it's a new working relationship, so I'm trying to be, my best behaviour and impress. And I was trying to explain to him what my intermittent fasting was. I couldn't count to 20.
Just to clarify, she said 24.
I couldn't count to 24. So Charles had to do it for me.
No, it wasn't that bad. No, you didn't stop the numbers the wrong way around.
Oh my god.
I think intermittent fasting, if you're doing the 16-8, makes you sleep better. Well, for me, sleep better, especially if you stop eating before 7 p.m.
Yeah.
Feel more energized.
I'm a fan. There's definitely something in it for sure.
See, when I tried intermittent fasting, just because of my routine, I always ended up having tea at around 10 p.m. But then that meant that I have to go until about 3 p.m, 4 p.m. the next day without any food. And it was actually decent. It wasn't too bad. It wasn't as difficult as I thought it would be.
I think the hardest bit for me was when you're preparing meals for your kid and stuff like that, and you aren't actually going to be eating that. That's kind of a bit of a torture. But yeah,
I'm
surprisingly.
lucky that Nina only has breast milk, so I'm not really that tempted.
You're not jealous.
Yeah.
On that note,
Right.
This week I learned about myself that everything tastes better that you eat if you serve it off a wooden tea tray, like one out of a 1970s cookbook.
Even breast milk.
Even breast milk.
I will get on the case, Don. Thank you for that.
I'll bring the
borrow your
tea
tea
tray. I'll
tray.
bring the tea tray. You bring the breast milk. Well, not you bring the breast milk.
Yeah, we might need Sophie for that.
Yeah.
Okay, so coming on to today's episode, we're going to talk about the relationship between patients and clinicians Now I know that both patients and clinicians listening out there are rolling their eyes at the thought of dealing with the others, but we'll just aim to get into why this relationship has generally gotten so bad over the years.
Yeah, I think who is it? There's an excellent TED Talk that we'll link to in the show notes by a woman called Sarah Krug, am I saying that? Krug? Krug. And she talks about that patient-doctor tango, and I guess we can replace doctor with clinician, and how much like an Argentinian tango, there's a sort of a back and forth between the clinician and the patient, and it's built around it's supposed to be built around like a balanced partnership, one with respect, a connection, rhythm, listening to the music, but continuous give and take, a bit of improv, intuition, to be able to navigate that encounter really productively. And we're going to dive a little bit more into each of these key parts of the relationship throughout the episode, aren't we, Don?
Yes, we are.
That's the plan, right?
Yeah.
Let's
hope so.
Let's do it.
I don't know what you've got lined up, but yeah, let's hope so. And if you're fishing for any more bonus content, you can find some more Tango-related snippets on our social media, or the whole video on our Patreon.
Smooth, nice segue. Yeah,
Thank you.
slip that in there. That's good. Seamless.
Get professional.
Yeah.
Listen to the end to find out more.
Cool. So, as a patient myself, I know it can be easy to go on a bit of a witch hunt for clinicians and blame them for all the negatives in the relationship. But I think we should start talking about the patients first and talk about what the patients do right and wrong in the relationship, and thinking about how those patients can get the most out of their relationship with their healthcare provider. So I want to ask you a question, Becky, as the one clinician around the table. Do you have a favourite patient? I know you can't say their name or
I was about to say Ryan.
Yeah. But what is it about them that makes them your favourite? What makes them a joy to work with?
Okay, well, before I answer that, I think I might sort of take issue with the whole, right and wrong. There is no right and wrong, and I can hear the eyes rolling. But I think we're talking about language here, so I think it's important that we sort of think about what we're saying, and I don't think there's a right way of doing things and a wrong way of doing things, but there's definitely a way that the relationship can be a bit more productive. So I think for me, the patients that I find I get the best connection with, that tango, as you say, are the ones that say, I'm willing to try anything, and they genuinely are. So you'll have some patients say, I'm willing to try everything, and you say, well, what I want to do is do maybe a mind-body approach, a more holistic approach, and they're like, yeah, no, I'm not going to do that. So patients who are coming genuinely saying, I'm open, I will try anything. And that usually is a really good starting block, I would say. Starting point. Yeah. To get out of the blocks.
Becky.
Can I just interject?
Yeah,
Becky's not going to like this.
All right.
It follows on from a theme from earlier in the podcast. When I corrected your lyrics, you said, I can hear the eyes rolling. The eyes rolling make a sound.
So to answer your question, Joe, these are the people I don't like. These are the ones.
I was just trying to do this with my own eyes and seeing if I could hear anything. And
Yeah, the
If
ones
you've
that
got
are
wet
really...
eyes, though, and I can sometimes hear myself blink.
Yeah. All right. Okay. Sorry.
So-
I apologise for questioning that.
But I'm going to go straight back to the three of you, because I know each one of you have sort of various sort of persistent pain issues. What to you, right from the get-go, so we'll get into sort of the dynamics, right? But I want the first 2 minutes, okay, we get a sense of whether or not this is going to be a workable relationship. I think you can get a vibe, can't you, within the first 2 minutes. So what would you say me as a clinician needs to do in those first 2 minutes to convince you guys that, it's worth your time being here?
Shall I go first?
Yeah, please do.
So as a layperson, I think I find it really useful when clinicians kind of break the terminology down. Even simple things that are very common these days, like a holistic approach, mind-body connection. Sometimes people might just refuse to understand that because they don't really know what it means, and they'll just not even go anywhere near that. So kind of reframing that into just easier words to digest might sometimes help.
Okay.
Because even so, just avoiding those explicit terms of mind, body, holistic, because that can sound a bit, just reframing it can help sometimes. And
Okay.
if the patient's seeing that the clinician's willing to go to those lengths, that can help improve that relationship.
That's good to know, because obviously we're told to avoid acronyms, you know, so the abbreviations, that sort of only medics and healthcare professionals talk. But yeah, even the mind-body connection, there's an assumption that everybody knows what you're talking about that. Yeah, and it's good. Okay, Joe, Charles, your turn. What would you say?
Well, I think that it depends, like, where that patient is on their journey. Like, how are they coming into your office? Like, how are they feeling? Because I remember, you know, from the first time I engaged with clinicians about chronic pain, you know, I was really bubbly and I wanted to learn and I was open to being told what to do, and I'd go off and do my exercises. Then fast forward a few years, I was walking into, you know, a clinician's office, like, really, like, pissed off at the world and angry, and, you know, so it's like completely different. You know, I'm aware of like that I was walking into the rooms with different mindsets, so it's hard to say one thing that I'd be looking for. I think just to feel heard and validated and understood, those things were always quite important for me.
So talking about like terminology and unpick that, break that down as to what it means to feel heard, because from my experience, both clinically and in research, this seems to be this barrier that, you know, we as clinicians are taught this thing when you're supposed to repeat back what the person said and stuff like that. To sort of, yeah, exactly right. Something along that. There's a term anyway, and we're taught it, and clearly that was good because I've completely forgotten what it was called. But so, you know, it's just to try and show that you are saying, like from what I'm hearing, it's this. From what I'm understanding, have I got that right? So you're just checking in every single moment just to make sure that there isn't some sort of prism effect where the light has gone in and it's just been refracted into and bent in different ways. And so you, as a clinician, you go, oh man, I think I nailed that. I think that went really well. And the next minute you're just like, didn't hear a word I said, didn't listen to me at all. And I'm like, is that because you didn't get what you wanted, patient? Is that because you went in and you wanted to get something from me and I couldn't deliver it, and so somehow I wasn't listening to you? It's really difficult, and it becomes really upsetting, I think, because you're like, oh my God, I really tried that time.
Yeah, well, a common theme from what I hear when I talk to people that live with chronic pain is that they find it hard to communicate with their clinician because because they don't feel that they could ever understand what it's like to live in constant pain. And I don't know how you get around that aside from inflicting constant pain on your clinician.
And I'm sure some patients would like to remind that.
I think, that's a tricky barrier because, and that's where the role of lived experience comes into play with chronic pain. But I think your example of like kind of repeating back what the patient said, I always used to try and put my pain in terms I thought someone else could understand. So I'd say to someone, do you remember what it was like to have appendicitis or to break a bone? Okay, how did you feel when you broke that bone? Okay, life wasn't great. Okay, yeah, but then it fixed and life got good. Okay, imagine that feeling of that broken bone every day for a year. What would your life be like then? And that is the closest I ever got to making someone feel like that they understood how much pain I was in. And if I felt that person did understand, then straight away a dialogue's opened up. Yeah. And I feel like I can talk to that person.
Yeah, I mean, I know it sounds really simple, and it is, and so I don't know why we don't do it more often, but usually, you know, you're so desperate to get everything down, and my memory is so absolutely atrocious. What I tend to do is I ask and I say, do you mind if I take some notes? And then I'm scribbling and scribbling and scribbling, and I'm hoping that what my patients see is that I'm like hanging on every word and I'm trying to jot it down. In actual fact, what is much, much, much better, put the pen down, put the notepad away, turn your chair and just go, lay it on me. Lay it absolutely on me. Let me get it. And then I try and make a note. And I'm not saying what I do. I've got a lot to learn and I'm not the perfect clinician by any stretch of the imagination. But I try and say at least once, I can't possibly imagine what it is that you're going through. Yeah. However, I think there's some things we can do. Just so it's just like loud and clear, I get it. Yeah. And if I slip up along the way and say something insensitive like, you know, oh, we all get back pain or something really insensitive like that, just in the heat of the moment, and I'm not thinking, I want to put it out there right from the get-go, hands up, have no idea what you're going through. And I hope that helps a little bit.
Yeah, I think so. I think so for sure. I think one of the problems that you have as a clinician, and that I'm getting a lot more empathy for spending more and more time with clinicians, is that your appointments are so short that you have the choice between either being that clinician hunched over the computer taking as many notes as possible, or giving the patient the attention and then just having no time to do the notes. And then when do you do those notes? Do you do them at the end of the day when you've got, well, you've not got time, but when you're off shift? Do you spend extra time doing those notes where you might not remember them as freshly, and you might not be able to give the patient as high a quality of treatment because you've forgotten something that might end up being pertinent?
Yeah.
But then equally, if you're spending your whole time hunched over, then your patient might just be like, they haven't even looked me in the eye.
Exactly.
Which is why I think the first 2 minutes thing you said, looking me in the eye and being like, I hope you're doing okay today, sit down, like, let's talk about how you're doing, let's work out what we can do for you. Just having that human interaction first, and then saying what you said, I hope you'll excuse me, I'm going to take some notes, I'm going to be hunched over here, but it's only because I want to capture everything. Yeah. Just laying out that, rather than being like, what are our expectations from this consultation? I'm just like, oh, fuck off. Yeah. What I want is someone to come in and be like, this is what's going to happen. Yeah. I'm going to give you the opportunity to talk, but this is how it's going to go down. I'm going to be taking notes because I want to make sure I give you the best standard of care that I can.
I mean, without a doubt, like the thing that made the complete difference when I moved into persistent pain is that I was given an hour with my patient. So then I could relax. I didn't feel like I had to rush. I didn't have to do anything. And that just makes all the difference. I mean, don't get me wrong. I'm still going over my time. I'm still dictating letters. I'm still working extra hours. But you know what? That's fine.
What probably makes your life a bit more tricky is that you get that hour and you've got that amazing sort of knowledge base to offer solutions or treatments to that patient. But they've seen, probably prior to getting to you, a load of clinicians that don't have that kind of pain education that you have, and have probably given that patient the impression that there's going to be a quick fix somewhere along the line, like a silver bullet or a pill or something like that. And so I don't know if you feel like you have to do this sometimes. You're like having to re-educate that patient on the spot against, like, potentially years of incorrect beliefs about what's going on. And so an hour's great, it's a great start, but it comes back to that, like, what kind of condition are they walking into your office in, like, it really is tricky.
I guess it might help, I don't know, but here's what happens in my hour. Okay, so before I see my patient, I spend a good 10-15 minutes going through all the patient records. And like you said, there's tons. They've gone to neurology, they've gone to rheumatology, they've gone to orthopedics, they've been to psych, they've been back to psych, round and round and round to try and get an idea of what they've tried, what's failed, and what they might have been told, so that what they're coming in for. Then we get probably a good 40 minutes of chit-chat back and forth, okay? Then they leave, I write up my notes, then I dictate my letter because it has to go to the GP and then any other healthcare professional. And then if there's anything else that needs to happen, I've then got to dictate another letter to do a referral. Now, this isn't an attempt, although if you want to, you can feel sorry for me, but this isn't an attempt to get the violins out for. Yeah. But it's just a sign of saying that even with that hour, it's a lot to do and there's a lot of unpicking. But you're right. Most of my clinical time is spent unpicking all the nocibic languages and all the nocibic messages that have been given in the past. And it's really difficult to do. It's so difficult to do.
Just very quickly for people listening who don't know what nocibic and nocebo are.
Well, that was me just dropping really fancy words so you think I'm really intelligent. So nocibic is basically words that can cause harm or damage. So sort of you will end up in a wheelchair. This pain will only get worse. There is no cure. 100%. Really helpful, delightful messages like that. So that's a nocibic message. It's causing harm just by you saying those words.
So that is the patient's belief in the healthcare system, is that whatever ails them, they walk into a doctor's office and the doctor will fix them. Mm-hmm.
Instantly.
Yeah. Bang.
Like a wizard.
Click of the fingers. Now, chronic pain couldn't be further from that reality. it just doesn't work like that. So, but you've got now patients with expectations that that's how healthcare works. You've got clinicians who, sorry, I'm going to speak for you and all your colleagues.
Okay, thanks.
now,
So go ahead,
Becky.
because clearly I can't even know what the CBIC is. So yeah, off you go.
Who probably have felt through that whole period where they were fixing, and they do have a lot of silver bullets in their arsenal, that they can fix anything. So, but now they're confronted with this new science about chronic pain, which probably makes them feel a bit like helpless, really,
Yeah.
because now they can't. So you've got one side expecting the silver bullet, the other side thinking they had it, now they don't have it, and there's just this chasm in the middle.
Absolutely, and it comes down to the training. I mean, so from a physiotherapy point of view, I've got absolutely no pain training whatsoever. I mean, obviously acute pain, but chronic pain is completely different, and the differentiation was not made apparent in university. So you come out thinking that you can help and cure people, and then to feel that all the stuff that you spent years learning about goes out the window is one thing, and then you're left looking in your tool bag going, oh my God, I've got nothing. I've got absolutely nothing. And possibly in your attempt to fill that void, you end up saying things that possibly aren't the most helpful, and you really struggle. And there is, I guess, perhaps that's where some resentment comes in, whether conscious or not, about like, you know, I'm really trying here, you know, and not feeling as if you are, you know, that the patient on the other side is recognizing that. And I think that's certainly an arc in my story coming from musculoskeletal physiotherapy, and I loved MSK physiotherapy because knee pain was osteoarthritis and ankle pain was because you went over it and you gave yourself a grade 3 lateral sprain. And it was great. I knew what to do, and, you know, 3 to 6 weeks later, people were feeling better. But as soon as I got people with back pain, that is where the term heart sink comes from. Not because the patient themselves, it's because like I can't do anything to help. And I think I feel badly for clinicians because they simply have been lack the training. Charles, you have your hand up. Yes, you.
So you said, I think at the beginning of that, you said something about a clinician not having any more tools to help the patient, and then you just said, you know, someone with back pain, you sometimes feel like you just don't have anything to help them with. Would you say that things like empathy and hope, as long as it's like not false hope, do you think those are kind of treatments that, so like essentially you never have an empty toolkit or like treatment bag, because you can always show empathy, you could always give hope, you could always do, there's always something that patient could leave feeling a bit empowered. So isn't that like something that you could always have up your sleeve?
You can, and absolutely. I think now that you're talking to me with a bit more experience down the line, and I'm now a chronic pain specialist, that to me is absolutely tools that you have in your toolbox. But if you're talking about a recently graduated physiotherapy student, they will not think that empathy and you know, hope is a tool. And therein lies the problem. That whole biomechanical orientation and training is, yeah,
those things are kind of hard to teach, I guess.
Yeah.
So what's some other key things that the patients need to do to have a good relationship with their clinician?
Bribery helps for sure. A good bottle of wine never goes too far.
Would you like to elaborate on that? What have you received?
French Chardonnay, and then I'm there.
Absolutely. I think one of the main things that patients have got to do is report honestly. So I know I spoke to Becky about this before. When I was a patient, or I still am a patient in some ways, but when I was sort of earlier on in my chronic pain journey, I got recommended to use certain keywords by other people with pain. So I'm not going to say what they are, because I know that people listening to this podcast will feel how I did and will want to use them just like I did. But you can get referrals by using certain words, because the NHS have these words where they go, oh shit, that looks like a red flag symptom, so we've got to refer them on. And people were using that to kind of game the system. But I feel like because there are a few people, and again, shamefully, I was one of them, that do that, it creates this distrust from clinicians, and then people who aren't lying about how bad their pain is or about what the quality of the pain is, they don't end up getting those referrals that they maybe need.
Yeah, but you can imagine the more desperate you get, the longer your pain goes untreated and your sense of suffering increases. You know, it doesn't forget, like a pain setting in life, as you get more desperate, you might be getting more hungry. You do anything that you think will help increase your chances of survival.
Yeah.
And if that's having to game a system, as you get more desperate, it's only natural. So again, we've got this situation that almost is creating this mistrust because I thought I said Liz Truss there.
Creating Liz Truss.
She is out of here.
I was going to say, that is
She's in
bad.
Beijing's pork market.
Yeah.
No, Shanghai's
mistrust. There we go. And yeah, so it's again another problem that needs solving. But yeah, you have that kind of built into the system, really.
I think you know, when you're triaging somebody on the phone and they do use certain words, yeah, possibly you can sort of maybe jump the queue if that's the right term. I do feel the more experienced you get as a clinician, the better you are at teasing out relevant information. So you might say a keyword that sort of raises flags, but if you're good and experienced, you as a clinician will know the right questions to follow up to really unpick whether or not that's something that needs to be escalated or something that can be sort of managed. So I would have said, the less experienced you are, possibly the keywords become more relevant because that's what they've been trained to look out for. But if you've got a really experienced clinician, then one would hope that just listening to the patient's story is enough and that patient doesn't feel like they have to, I'm using air quotes, layered on thick. They don't have to look like they're ill. They don't have to be in a sick role, that they can tell their story as they are in the day that they're presenting, a good day or a bad day, and it shouldn't make any difference to a good clinician's ability to know what they can do to help.
But I think when looking at the UK healthcare system, a lot of these they are used to having to appear as ill as possible in order to get whatever the benefits that they're supposed to get. So if they're core having a good day, they kind of risk losing that money that they need to survive. Dr. Norton Hadler once said, if you have to prove you are ill, you can't get well. And I think that's the same, and it's very true for patients. They feel the need to appear very ill in order to get help. And then doctors start to distrust patients, which in turn it's just a cycle.
Yeah, I really like that quote. I hadn't heard that before, and I think it's so true. And when I was doing my research for my PhD, it was a common theme. Like one of the participants said that he had been absolutely debilitating pain for like 3 days prior to his orthopedic consultation. And on that day of the appointment, for whatever reason, he was feeling better. Consultant said, "Oh, look, you're walking much better." And he was out the door within 3 minutes. And do you know what? I've heard enough stories to believe that that is exactly what happened. So, yeah, it's so difficult. You know, I do sometimes feel like patients feel as if they need to look sick in order to be taken seriously, especially when you're talking about pain because it's invisible, you know? It's really difficult.
Yeah, it feels like as you improve, I'm speaking for myself now, but I remember as I got better at managing my pain, so you start having more kind of good pain days than bad pain days, you become a victim of your own success. You like put in all this like insane work, but you have to take your mind to these really like challenging, dark almost places where you have to tolerate all this pain. And by doing that, taking yourself to that place, you get better at it and your pain thresholds increase and your endurance increases. And so when you go and see the doctor next time, you're better than the last time. You're better than you were when they last saw you. But he hasn't seen, or she hasn't seen, that like ridiculous journey that went in between. So you just walk in and they say, oh, like things are better, you're in less pain.
Yeah.
Like whether you had a prescription before, I'm not going to give you that anymore, or you don't need that treatment we were talking about. And yeah, you shouldn't be a victim of your own success.
Sure.
Yeah.
Yeah, and as you said, pain is invisible, so it's really hard to vocalize.
I think as well with patients having that reduced pain, I think there's a lot of patients who feel the need to underreport as well. So even if they're not feeling less pain, they feel like when they go to see a doctor, say you go to a pain clinic and 3 months later you go back to the same pain clinic, you feel like that doctor has an expectation of you, that clinician has an expectation of you, you should be better by now. There's no, especially if you've got a condition like fibromyalgia where there's no concrete physiological reason that you can see on an X-ray or an MRI or something, clinicians are expecting those patients to get better, and patients feel that pressure, or actually clinicians like Becky who have been in the game for long enough are hoping that patient is better and doing everything they can to make that patient better, but it's not an expectation.
Yeah.
But you've got a lot of clinicians who are expecting the patient to get
Yeah.
better, and the patients go, well, I'm going to tell them I'm feeling in less pain, or they want to appear tough, or they've brought a family or friend with them and they want to make them feel less worried because they don't want to go in and say, I've been feeling suicidal, my pain is a 10 out of 10, I feel like I can't walk most days, I can't sleep, I can't cook for myself, I can't dress.
That's a really good point, if I can jump in on that.
Yeah, of course.
Because a lot of my patients ask me whether or not I mind or not that somebody comes with them. And I can say categorically, I don't mind. Because usually exactly that, Joe. What will happen is Mr. Bloggs will be telling me how well he's getting on and he's sleeping a lot better. And Mrs. Bloggs will be just like, darling, no. You have been up X, Y, and Z, blah, blah, blah. And he's like, no, it wasn't that bad. It wasn't that bad. I'm like, I'm the person you tell.
It can also go the other way. So,
yeah, absolutely. It can go the other way for sure.
So if there are things that Mrs. Bloggs doesn't know that Mr. Bloggs is going through, she'll just be like, why haven't you told me about this? And then that's a whole kerfuffle.
Yeah, you do have to be careful. You always should ask the patient, just like, do you want Mrs. Bloggs to be here and stuff like that? And to be honest, there has been occasions where I've just gone, do you know what? I think what I'd like to do for the next part of the consultation is just have a one-to-one with Mr. Bloggs and have a chat. If you can see that that's the vibe going on. But more often than not, in my experience, it's definitely the other way, where the patient is sort of saying that things are better than they actually are, and then you get the truer picture from their partner or whatever. Yeah.
Are the Bloggses still happily married?
And going strong.
Oh, really?
45 years, absolutely.
Amazing.
Yeah, it's
They've
magical.
recovered,
Magical.
They've recovered.
Send them my regards.
I will do. Will
Little
do.
mini Blogsies.
There was I know I'm just kind of jumping around a bit, going from that underreporting back to overreporting, but there's one thing I think that we need to mention in this episode, and we're going to do full episodes on these in the future, and we've got some great guests lined up for that. I think some of these patients suffer because they're female, because they're not white, because they're not cisgendered, because they're part of the LGBT community. And so historically, like, these groups have been so undertreated for their pain. And so there's either this reluctance to engage with the healthcare system in the first place, or there's this incentive to over-report your pain because you assume that you're not going to get believed that it's if you say it's a 7 out of 10, and they're just not going to believe you, then maybe you would be inclined to say it's a 10 out of 10 to try and be taken more seriously.
Yeah, I mean, I don't know a lot about these different sort of minority groups, but I feel like one group that I can speak on behalf of is women, and don't even get me started about women and, the lack of research into women and pain-related disorders like fibromyalgia and endometriosis, which is obviously present. It's obviously present in females. So I'm trying to speak and look at who the author was of this book called Pain and Prejudice. Now, I know you guys are going to do another podcast on this, but do yourself a favour and read Gabrielle Jackson's Pain and Prejudice, because, how women have been treated and what little research has gone into pain-related disorders for women is atrocious. Not to mention all the other groups that you mentioned, Joe, as well.
I don't know the fact. Maybe, Joe, you might know these, but basically, you take a man in the emergency room and a woman in the emergency room, they're both screaming their heads off. Something like the evidence says it's quite common for the man to be given opioids or pain relief, the woman to be given benzodiazepine, something to calm her down, and the man's problem, suffering, is attributed to pain, and the woman's is attributed to hysteria. And it's like an episode that will pass.
And even worse if you're a black woman.
Yeah.
Like,
the
next level,
absolutely.
because it's the kind of average treatment is a white man will get an opiate, a white woman will get benzodiazepam or something similar to that, and then a black woman will get nothing. will basically just be told to sit down and shut up. So, like I say, we will cover that in
Yeah, there are
future
loads of
episodes.
academic papers show that female patients, they sometimes feel like they have to dress a certain way to make them look weak and groggy, because as when they dress in smart or athletic clothes, clinicians just assumed that they were not ill, and they were just, they were fine. They weren't.
Boo.
Boo,
That is
indeed.
bad.
But thinking of all this honesty stuff, so my mum was a GP for the best part of 40 years, and she gave me some great advice, which was for patients to try and be as honest as possible and to sort of disclose everything that you're feeling and every symptom that you've got, because if you don't, your clinician can't get the full picture of your health. They can't give you the best of their abilities. And my mum was talking more about people being embarrassed about showing off their genitalia or rectum or whatever, having a finger up your backside in a medical appointment. And my mum said to me, she's like, don't worry, I've seen more penises than you've had hot dinners. But my
Was
mum
that
said
before
this...
she was a GP or?
Yeah. Wow. No, my mum... But she said this to me at a time when I just started secondary school. And I only ever had packed lunches in primary school, so I'd only ever had three hot dinners by this point. So I was like, either as a clinician, she's seen a massively underwhelming number of penises, or she's using it as a turn of phrase. But either way, I digress.
Yeah, my apologies, Dr. Butlin. Sorry,
I kind of don't want to go out for the hot dinner we were planning on having later.
Exactly.
Just get a sandwich in or something.
Yeah.
So, as you all know, here at Pain in the Podcast, we try to keep things as at least partially lighthearted. So, in preparation for this episode, we were researching communication between doctors and their patients, and we found an excellent Reddit thread of things you can say during sex and a doctor's appointment.
Oh, right, nice.
So we've got a few of these ones written down in our notes here, and I would like to just take the first one if that's okay, because it is my personal favourite. Probably best to have a course of antibiotics, just to be on the safe side.
I'm going to take this one. You'll feel just a little prick here, and then we're done.
Stole mine, and I thought it top of my head. Oh,
Charles hasn't even got the notes in front of him, and he came up with that one.
Oh my gosh.
What's another one?
Actually, sorry.
Go ahead.
I didn't have the word prick in my head, so I was going to say you're going to feel a sharp scratch. And you're going to be like, Charles, what are you doing in the bed?
You need to see a doctor, Charles.
Fingernail thing.
What's some others? I came early, as expected.
Yeah. You've been in the waiting room.
Yeah, all done. Come back and see me in 6 months.
I've actually said, like, if you just want to jump on the bed and take off your trousers. And do you know what? I think once you've done that once, you can scratch that up to an error. I think I've done it 4 or 5 times. So it's just like, yeah, you know.
When you say you've done this in error 4 or 5 times, are you talking about with a patient or at home? You've had your clinician voice on, and you decide to jump on the bed and take it.
No comment.
Wait, do you have a clinician voice? Like, what's your clinician?
Oh, 100%. Yeah. I drop a little bit and I try and be a little bit lower. No, I don't. What I try to do is speak a little slower, because I speak at 1,000,000 miles an hour. So that's quite difficult when I'm doing telephone consultations. But no, I don't think I've got I'm saying that, but now I'm deliberately doing it.
You're very slowly
No,
now. Yeah.
I don't think I have. Why, do you think I have? Do you think it would be better if I did?
Oh, 100%.
Oh, right, okay, cool.
I hate your normal voice.
Okay, no, right.
I think you might do, though, because before when I asked you, I said I had some pain in my shoulder.
Oh, yeah.
I think things just changed slightly. Got a bit weird, actually. I thought, who is this person?
Just jump on that, Charles.
Yeah, you wouldn't take off your trousers, so like, wow.
It was his shoulder.
Non-compliant patient. But it's just my neck, Becky.
Yeah.
Take your trousers off.
Now, before we get onto the clinician side of the bargain, let's give you an ancient Egyptian laxative of the week.
Okay.
This time it's an enema, and it's a good one. Musk melon.
This is a feature for Charles and Becky looking very confused.
Yeah.
In our first ever episode, we spoke about the ancient Egyptians having a principle called Okdu, where basically to treat any disease, they would just try and get as much out of them as possible, and their favourite was to do it via the rectum. So, for example, they would put marshmallow up there. Not like you're imagining it, but the plant marshmallow, which has the same consistency.
How do you know what I was imagining? You're not in my
I was
brain.
going to say that's a waste of a good s'more.
Well, I guess it would come
It'll
out
get
brown.
brown.
Either way. Am I right, Becky, in saying that when you have a patient, right, you want them to...
I don't stick marshmallows up.
No. I'm moving on.
Don't take their trousers off.
Right, yeah. Moving swiftly on.
Please.
So when you've got a patient, Becky, you, in an ideal world, from what we said, you want someone that engages, they take your advice, they communicate well. Is that fair to say?
Yeah, absolutely.
So I went looking for what clinicians generally think makes a good patient to see if they thought the same as you. And I found something very interesting, and it made me come up with this game. So welcome to good patient versus good dog.
Good dog.
Good dog. The premise of the game is simple. I'm going to read you a statement, and you have to tell me whether it's from an academic article about what makes a good patient, or whether it's from a website about the characteristics of a good dog.
Okay.
Okay.
All right. Okay.
Right.
Let's start with number one. We'll give you an easy one. Polite.
So we have to guess whether or not it's the website describing a
Good
patient
patient.
or...
So an academic article, so a proper published academic article describing what makes a good patient, or a website about what makes a good dog. And it's got all the different qualities of different dog breeds.
Am I playing this game as well?
You are, absolutely.
Good patient.
I'm going patient.
Good patient. Easy one. That's the first one, right. Obedient.
Oh, that... Please,
Good
please,
dog.
please, God, that's a dog.
It's a patient.
Oh, my
I was
God.
gonna say
Oh,
Obedient, yeah. Okay, so
Paternalism.
please keep your scores on the doors. It's 2-1 to Don right now.
Yeah,
So please,
damn.
please keep a tally
I'll
of your
slurf the mark. Right, I'm ready now.
right. Able to maintain focus.
Definitely a patient.
Definitely dog.
Oh, it's a golden retriever. Don is storming away with this.
The psychologist has got this.
Oh, that'd be a patient. Okay.
Nope. Intelligence.
Patient.
Dog.
Dog.
You all get a point. It's both.
Okay.
Thank you.
Physical cleanliness.
I think that's patient because I
Patient.
once read a clinician's letter.
What?
Clinician.
Sorry. I was having a little bit of a moment there. A clinician's letter, and it started with this really polite, well-dressed lady. I'm like, what on earth has that got to do with absolutely anything clinically relevant? But apparently, this lady was very well dressed, so good to know. So yeah, ridiculous.
Are you the same? Are you thinking
Wait,
patient?
what was it?
Physical cleanliness.
This?
I'm going to say dog for this one.
I'm going to say patient because I know that they like to comment on whether or not the patient is well
I feel
kept or
like
not.
if it was a patient, they would have used the word hygiene. I'm going to go with dog.
I'm going to go patient.
Becky's the only one that's got this right. It's
Bing,
a patient.
bing, bing. But I
She's
feel
cheating,
like-
she's a clinician.
I know, but I also feel like I really don't want to be right because it's really just so wrong. Okay.
Number 6. Adaptable.
That's a dog.
Dog.
It is a Boston Terrier. Number 7. Number 7.
Number 7.
Number 7. Okay, that makes it fun. Number 7. Grateful.
Patient.
Oh, patient probably.
Dog.
Patient. Sorry, Charles. Sorry.
I'm pretty sure I'm winning.
I'm not going to be invited back on this podcast.
Okay. Patient.
What?
Patient. The word
Oh,
patient.
dog.
Like patience.
Dog.
Dog.
It's patient.
That's
Patient's got to be patient.
stupid.
Apparently.
Patient.
I don't
Oh.
think patient's a patient. Are patients patient?
Not in my clinical experience,
Exactly.
but with
We all-
well good reason, to be
Well,
honest.
Waiting in
That's why they need to be patient,
Yeah.
apparently. And number 9, able to bark on command.
Patient.
Patient.
But
Impatient patient.
an impatient patient. Either way, you get my point. So I think it's kind of
Yeah.
crazy that there's this idea that clinicians should still be revered by patients. I get that 50 years ago when people didn't have access to the internet, there were a lot fewer people at university, there could be more gatekeeping of that information. But now I think patients, some of them get information from the wrong sources, but there's a lot out there for patients to educate themselves. So I find it kind of crazy that there's still this idea that they need to kind of be obedient and things like that. Those kind of adjectives are pretty scary, to be honest.
Yes, but you do get the WebMD brigade that
For sure.
think they're overnight doctors.
Yeah.
So we need
Charles.
So yeah.
Okay, so I have a question for you, Becky. When I've talked about my chronic pain with Joe, he's mentioned different possibilities of what it could be. Mm-hmm. But whenever I've gone to, so mine's to do with my nose, and so whenever I've gone to the ENT, they've just diagnosed it as one particular thing, and they've not managed to really fix it. So if I was to do the whole WebMD thing and come to you with a bunch of options that I think it might be, how would you react to that?
So if what I'm hearing you say
Clinician voice.
is that you have done your own research and you have sort of married up your symptoms and come down with, say, 3 possibilities that it might be that makes sense to you.
Yeah.
And your question to me is, how would I react if you came in with this?
Yeah.
So I have had many patients come in with a full lever arch file of sort of their condition and their various consultations and what they might be. Yeah. Well, yeah, they've had it for a very long time. To be honest, and I'm not just saying this, I think it's quite useful. Not necessarily because you've come up with the right diagnosis, you might have done, for sure, but also it tells me a lot about what this is for you. In other words, you've done a lot of research, it's clearly playing on your mind, you've had it for a long time, you're really worried about it, nobody has given you any reassurance to date. So I'm sort of inferring from all of this. So it's what this pain and what this condition is having for you. And to be honest, it might be you're bang on the money. So a lot of the times I ask my patients, what do you think it is? For instance, it's always, mainly for me, it's like fibromyalgia. They're like, oh, my doctor told me I had fibromyalgia. It's like, and what do you think? And some people were going, well, thank God, because as soon as I found out about it, it's bang on the money. And then the others say, no, I've done my own research. It's not fibromyalgia. Don't you fob me off with that label. And it leads to a really good dialogue. So I actually I feel like the answer is, I feel threatened and, don't go onto Google Doc because, I'm the professional. I don't actually. I think now but I think that's because I'm a lot more experienced now. So I'm a lot more confident in my own abilities and I don't feel threatened. I think if you asked me when I was newly graduated and you came in like that, you would be a nightmare patient and I would run for the hills in terror. So yeah, I think to answer your question, I think now it would actually be a useful beginning to start a dialogue.
Oh, and that is what you call empathy.
Boom! Yeah. Nailed it! Please can we end the podcast now on a high?
So one of the things that we hear from people we know with pain time and time again is that relationships break down because the patient doesn't feel like they've been heard or that they're believed. Now, a big part of this is because for a very long time, we've had an empiricist medical system.
One that's based on objective measures. So one that you can empirically test. So if it's not objective and it's not measurable, then it doesn't exist. So it's at an empirical level.
Yeah. So what that means is that for a clinician to comprehend and believe your experience of an illness, they often need a clear biological sign.
Yeah.
For example, if you can see the bone sticking out my leg, you pretty much know that I've got quite a lot of pain. But if I have a complex regional pain syndrome and no clear cause for my pain, then a lot of clinicians often resort to calling it psychosomatic, which patients quite rightly understand to mean it's all in your head.
Dun, dun, dun.
You psycho.
Yeah.
We need a throughout the series, just it's all in your head counter.
Yeah, that's absolutely. And there's a historical basis for this, why this is the case. Because, back in, 2nd, 3rd century CE, a Greek physician called, I'm going to say Galen, possibly Galen. Galen. Yeah, Galen, let's go that. He pioneered dissection and encouraged doctors only to believe in an illness if there was a biological reason, like a pure, understandable, pathological, sinister reason that they could see with their own eyes. And so for conditions like fibromyalgia, that just doesn't fit the bill because, it's not visible. There's a ridiculous historical example in, I think it's 1881. An American neurologist, William Henry Hammond, said, quote, "The fact that a patient denies the existence of tenderness should have no weight with the physician." So, in other words, he believed that whatever a patient said, positive or negative, was of no consequence, and the only things that could be empirically, biologically evidenced was important. In other words, if you can't see it, it doesn't exist. And so this has been going on for centuries, so no wonder it's taken such a long time to unpick this ingrained cultural phenomenon.
Yeah, for sure. I mean, the problem with this is pretty obvious because most chronic pain conditions are invisible. So there's this kind of disbelief, but actually what happens a lot of the time is that there can be natural biological changes that occur over time, but we're so desperate to give them a biological cause that we start relating them to unrelated things. So the stat that kind of everyone in the chronic pain world quotes is that when you reach 50 years old, that population, 80% of them have got disc degeneration.
Yeah.
And when I say disc degeneration, people at home will be like, oh, my back's really sore just thinking about that. But they don't realise that's normal. Like, there's skeletons of T-Rexes that have disc degeneration evidence. Like, this was really like maybe that's why it died, who knows. But it's a part of normal...
Not the message we're going for there, Joe, not the message.
But it's a part of normal life, right? But I think we're so desperate, like, as a medical community, to find clear biological causes that we'll just associate normal wear and tear with things that aren't related, and so patients have unnecessary surgeries, and it just ends up making the pain worse.
Totally. There's like, before I got into chronic pain, as I said, I was a musculoskeletal physiotherapist, and I loved the shoulders. Shoulders were my thing. And there was this really interesting paper, and we can put it in the show notes because it escapes me at the moment. But they did autopsies on American professional baseball players, and all of them, pretty much bar none, had huge rotator cuff tears. Some had complete ruptures as well, and yet we're still playing baseball at an elite level. And so we're trying to say that even if you've got a tear in your rotator cuff, you don't have to go for surgery. In actual fact, that can make things worse. You can rehab a rotator cuff injury. You might not necessarily repair the tear in itself, but the body is incredibly resilient and it can compensate in other ways. So I think, hopefully, things are changing in that direction, but it's just to go to show that even if you have got objective things, that doesn't necessarily correlate to how people are feeling, their pain, and I think it's important. And this makes me laugh because when I first got to know Joe, I was interviewing him for my research, and we kind of quoted at the same time this quote from Margot McCaffrey, and it's basically, quote, "Pain is whatever the experiencing person says it is, existing whenever the experienced person says it does." Like, yeah, okay. Margot, I think I can say it more pithy. It's just like, pain is whatever the patient says it is. End of, full stop, end of story. And I think if we can start from that basis, then I think it go a long way to repairing the clinician-patient relationship, clinician relationship.
Yeah, I think that the majority of the problems, other than belief, all come from poor communication. And I think I broke this down into 4 different types of communication and made little notes on them, but please, you will all have stories like this, like Charles and Don, you'll both have very similar experience, I'm sure. But the bad communication that patients often experience with clinicians who aren't pain educated is the patronising. So I was 6 years into having chronic pain, and I had 2 GPs in the same year suggest that I tried paracetamol.
Did it fix you?
Yeah, did you?
Oh, you fixed me,
Did
yeah,
you?
exactly.
Yeah.
That's why I'm here, Charles.
Yeah.
So I think that's it happens far too often. There's the well-meaning but dangerous, which is I went to a pain clinic, and I won't say where, but went to a pain clinic, and this clinician I think was clearly wanting to help me, but didn't really see what options they had. So they were just like, what drugs would you like to try? Would you like to try morphine? Would you like to try benzodiazepam? Would you like to try whatever?
I just have a vision of them coming out with like a tea trolley, like the old cake system.
Oh, I
Just
immediately
like-
thought of what's that show where you like go shopping and like try to put as much as you can in your
Supermarket
shopping.
sweet.
Supermarket
Sweet.
sweet.
Oh, I thought maybe you were like in a Medellin, like open air market, like in the kind of like
Yeah.
90s, like instead of a hospital. But yeah.
I think I'll try a fentanyl patch with a little oxycodone, please. Thanks so much.
Yeah, so I think there's people, like Becky said, sometimes when you feel like there's nothing you can do to help, you just go scrabbling for anything.
Yeah.
There's the outright shitty. So I had a time where I ended up being hospitalised because of my pain, ended up being sent to A&E, and we knew, my GP who sent me knew it wasn't the right place to send me, but there was nowhere else to send me. And I had a nurse who basically just said, I don't believe you're in pain. You're wasting our time. You shouldn't be here. Like, surely you should know if you've got chronic pain that we can't help you. Like, you should have a better understanding of it. And I just thought, like, I was in tears at this point, partially because of the pain, but also partially because I was just thinking, like, I am in my most desperate point. and there's still this lack of belief. So I know like Charles has had the same.
So what is the like right pathway at that moment in time? Like what is the suggested? You know, because it's right. A&E is not the right place to be. I've dragged myself there many times. I don't know. I think now, yeah. I definitely haven't been for chronic pain in the last 3 or 4 years. I don't know. I don't know what the solution is now. I would just probably bite down on a pillow and wait.
Yeah.
Which is weird.
I'd love, as the clinician in the room, to give an answer to that.
Yeah, please do.
And to be honest, there isn't one. The NHS still isn't figuring it out, and there's just so many people and growing in numbers living with persistent pain conditions, and the simple fact is the NHS cannot handle the sheer numbers, and we don't have enough clinicians. So they're bottlenecking, and people are going to A&E, and it's completely and utterly understandable, but something needs to be done. And the NHS is definitely struggling. And I do, full disclosure, I don't think anybody in the NHS would disagree with me on that one. But I don't think, in answer to your question, Charles, I don't think we have an answer yet.
Yeah. We've got to hope that it comes up soon enough.
Okay, so this is getting a bit low in energy.
Oh, I have one thing that will make it not low in energy.
Oh,
the final
right.
communication method. I'm very sorry.
Okay, I apologise.
It's the bizarre. So this is completely unrelated to... Well, it's not unrelated to my pain.
Tarot. Did you try tarot?
I didn't try tarot.
Magic mushrooms.
If only. I was in hospital in A&E another time, and they wanted to work out what was the cause of my pain. And they do the nerve activity test. They get you to squeeze, they test your reflexes and stuff, and then sometimes they say that's not necessarily enough. So the way in which they can do the more in-depth nerve conduction stuff is by sticking a finger up your backside and having you squeeze it.
You've spoken a lot about sticking fingers up backside.
I have, but it was all coming to this.
Wait, so this happened to you?
This happened to me. So they stick a finger up your backside and ask you to squeeze it to test that your nerves are working well, like your nerve system.
Yeah, we don't do that anymore, Joe.
Are you sure? Oh God! Are you sure this was in a hospital?
Yeah.
Like you've been offered a lot of medication, sounds like weird, and now you just
the veterinary surgery was just on the opposite side of the road.
Question about what you would say in the bedroom and in the office. Now you're
Well, speaking of what you say in the bedroom and the office, I got the best compliment of my life during that interaction, which is she went, "Mr. Parsons, your anal tone is top notch," and I was like, "This has to go on my CV."
Absolutely. Would you like to go for dinner tonight?
Exactly. I bet you say that to all the boys.
Okay, all right. So let's finish off our focus for today's episodes with some constructive advice for both patients and clinicians about how to get the most out of their relationship with one another. God, I feel like I'm in marriage counselling, but I guess it's a little bit like that. So patients, I'm reading from my notes, treat your clinicians with respect, brackets, wine helps. No, that's optional. Treat your clinicians with respect and understand they have to know an awful lot about an awful lot, and so sometimes they'll not know about your whole medical history, and it's super frustrating for you. But unfortunately, clinicians often, just don't get enough time. So I think a little bit of patience and understanding on both parts go a long way. So to make lives easier, make notes before you come to your appointment. As I said, I have patients bringing in lever arch files. We might not get to all of it in the one consultation, but certainly write down anything that you think relevant, especially when you're on a lot of pain medication. You probably haven't slept very well. So it's really difficult to sort of remember everything that you've been told and to remember everything that you want to ask. And there's no doubt about it. There's a white coat syndrome as well. As soon as you've sat in the doctor's appointment, everything goes out the window. So take notes, both with you and during the consultation, and record anything that you're worried about. And if you're feeling nervous about seeing a clinician, as I said before, bring in a friend or family member, someone you trust, that can give you a bit more confidence so you're able to communicate what you want to, but also to perhaps convey a different part of the story that you're not able to verbalise or articulate yourself. And be honest, a lot of my patients say, I'm so sorry, or I don't want to be moaning or stuff like that. Oh my God, I'm the person you moan to. I'm the person you tell. Give me honest answers and information, and that will go a long way. And on my part, on behalf of the clinicians, we will just try to listen more, understand more. And I think we just need to learn more. And the people we can learn from are the people with those lived experience. Oh my God, I'm getting goosebumps. I'm getting a bit emotional. It's been a long day. But yeah, I think, any other points, Charles?
I think for patients with chronic pain, like, try and set realistic expectations when you're walking into a clinician's office, and not just in like on the points we've just spoken about, that the clinician might either not have enough time in that appointment or have the right understanding of pain, but also like your own responsibility. Like, your life has been shut down because of pain. You've got 168 hours in a week. Be realistic. You're not going to get those 160 hours fixed in 1 hour. So what are you doing in the other 167 hours? Take some responsibility for those 167 hours.
And clinicians, believe your patients, believe their descriptions of their pain, treat them as an active part of the team, and show how you have empathy and that you are actually interested in what they have to say. If you're able to, try and read the patient's notes before appointments, because if you haven't, a lot of patients will feel like you haven't really made the effort, even though you may be snowed under with a whole lot of other work. Also, communicate at a level that is suited to your patients and that's tailored to them, and then give them the opportunity to ask questions as well.
Yeah, is there anything else anyone wants to add?
No, I think that's about it.
Okay.
Yeah, that's good.
So we will transfer seamlessly to a recording that we're doing later on, which is our book review this week. So today we are going to be doing a review of Pain, the Science of Suffering by Patrick Wall. Now, Pat Wall passed away back in 2001, but before that he was a prolific researcher in the chronic pain field, best known for his work with Ronald Melzack from McGill University, where together they came up with the gate control theory of pain, which the basic idea is that a painful stimulus can be modified in the spinal cord and in the brain, and it affects how much we end up feeling in the end. It affects the quality and experience of our pain. Now, that theory has since been developed upon, but it was the first really modern theory of chronic pain. And Pat Wall went on to have huge numbers of publications, and we'll put a few of the classic papers in the show notes just so you can see how prolific he was. But this book, Pain, the Science of Suffering, is a really great place if you want to start delving a little bit more into the science and politics behind pain. So he talks a little bit about the clinician and patient relationship, like we have done today, talking about the lack of belief from some clinicians. He talks a little bit about specifics around how pain works, so how different nerve fibers fire. He speaks about how women are conventionally undertreated in pain, and again, like we said earlier on, that there's this prescription of medication for analgesia for men, while women often get sedatives. It speaks about the societal impacts of pain, where huge numbers of people take time off every year to deal with chronic pain. And it talks about how to move forward with the management of chronic pain. And this was back in the late 90s that this book was written, so some things have been fulfilled, some things haven't, but it's a really great piece to help build your knowledge on chronic pain. So that is Pain, the Science of Suffering by Pat Wall. And now we will come back and finish the episode.
So with that, we wrap up our patient-clinician relationship episode. If you want to learn more, you can see all of our references in the description below. And as every good podcast does, we got a Patreon, bitches. If you like what we do here at Pain and in the podcast, and you can spare £1 or 10 each month, wow, that's a lot.
Yeah, I was going to say, you
guys
really
are
like
£1
you really escalated quickly.
You guys are so generous.
You better have some sweet merch. I want merch for that.
Would you like to? If you'd like to design our merch, please get in touch.
And if
Send in your designs.
And if you donate to us on Patreon, you can hear outtakes like these. You can hear outtakes, watch behind the scenes footage of us making the episodes, and even get little bits of bonus content along the way. So even if you choose to donate £1, £5, £10, 10p every month, it goes a long way towards paying for the wine during these episodes. So
it's a large requirement now.
Yeah, absolutely.
It is. It is. So thank you all for listening, and see you next week.